Well, hello, guys. My name is Brandon Ayres. I'm from the Cornea Service at Wills Eye Hospital and Ophthalmic Partners of Pennsylvania. And welcome to the Best Practices in Keratoconus Management podcast. Now, on this podcast, we ask questions of experts around the country as to tips and tricks on keratoconus management and especially collagen crosslinking. And in prior episodes, we've talked to practitioners, we've talked to administrators, we've talked to technicians, all getting tips and tricks. But this is going to be a very different and special episode. So I want everybody to take a deep breath in, inhale, exhale. And what is that? That's oxygen. So we all know that oxygen is critical to life and functions here on Earth. But how essential is oxygen to collagen cross-linking? So today our guest is going to be Tomas Navratil. He is Chief Development Officer at Glaukos and head of all research and development. And there may be nobody else who knows more about the role that oxygen plays in collagen cross-linking. So Tomas, thank you so much for being on this podcast and allowing us to ask you some questions. Tell me, just what is your role with Glaukos? What do you do and how important is oxygen to you and in collagen cross-linking?
Thank you so much, Brendan, for that kind introduction. I'm the Chief Development Officer, and with that, I have the privilege and the responsibility to work with the great team at Glaukos to advance the R&D pipeline and new therapies for patients in need. And so from that perspective, we are truly grateful for highlighting the role of supplemental oxygen in the treatment of keratoconus with the epithelium intact, which is the future of the keratoconus treatment in the 21st century. As you know, keratoconus is really a type of corneal disease in which the progressive thinning of cornea results in a distinct cone-shaped topography and produces blurred vision or distorted vision, which interfere with the patient's quality of life and can lead to blindness if allowed to progress without treatment. And we know that in severe cases, a corneal transplant is needed to prevent further disease progression, but that can be risky with the potential of graft rejection. And so what we have here is that despite the demonstrated ability of corneal cross-linking to produce truly significant advancement in patient care, the traditional protocol requires removal or debridement of corneal epithelium and takes at least 1 hour to complete. So not only this causes painful side effects associated with prolonged wound healing time and an increased risk of infection, but also the extended treatment duration may be intolerable for certain patients. And that is why the Epi-on procedure, where we preserve the corneal epithelium, is so important. But there's, of course, a caveat, though, and that is Epi-on does not work without supplemental oxygen. And so that is why Glaukos treatment, Epioxa, is such an important improvement in patient care, as it does both things. One, preserves the corneal epithelium, and two, also preserves the efficient type 2 cross-linking that is facilitated only by the supplemental oxygen.
So no doubt, Tomas. I mean, we have this discussion every day in the office with patients who have progressive keratoconus where, we've got great news for you. We have a treatment that we can do that's going to stop your keratoconus. I've got bad news for you. I'm going to have to make a scratch on your cornea, and that's going to lead to a couple of days of discomfort. You've got the risk of infection. It'll take you several days to recover, and it may be, several weeks or even months before you're completely done with this. And a lot of the problems that we encounter with the current epithelium off collagen cross-linking procedure, it relates to the epithelial defect. And so it even delays in some cases patients wanting to have the other eye done because it does hurt for a couple of days, even though we try our best to manage that cross-linking, manage the discomfort. But when we do that cross-linking, I do it just in the office. We have our patient, we have a cornea, we have UV light, and we have our Photrexa or our riboflavin. I don't pump oxygen into the room. So there's got to be a role for that supplemental oxygen. And you mentioned kind of this type 1 and type 2 process. What are the differences there in that type 1 and type 2 process?
Yeah, thank you. That is a great question. As you know, cross-linking involves riboflavin, oxygen, UVA light, and a substrate that cross-links, which in this case is the collagen fibers in cornea. So in the first step of this cross-linking reaction, riboflavin functions as a photosensitizer, where it absorbs energy from the UV light, it excites, and it becomes reactive. And here is where the reaction truly bifurcates. Type 1 cross-linking occurs in the absence of oxygen and is generally slow and inefficient. In this type 1 cross-linking, the excited riboflavin slowly transfers energy to collagen and forms crosslinks. In contrast, type 2 cross-linking occurs in the presence of oxygen and is fast and efficient. In the presence of oxygen, the excited riboflavin transfers energy to oxygen, creates reactive oxygen species that rapidly react with collagen and form crosslinks. So this type 2 cross-linking process is fast and efficient because the excited oxygen species are very reactive and therefore very short-lived. So in oxygen-rich environment, this type 2 process dominates, but if oxygen is allowed to deplete under continued UV irradiation, the type 2 process ceases and only the slower, less efficient type 1 process occurs. Therefore, it's truly critical to maintain oxygen levels to maintain high cross-linking efficiency of the type 2 cross-linking reaction in the epithelium-on procedure. And so we can ask, how is this photochemistry relevant for the treatment of keratoconus? In the corneal cross-linking, we want to truly keep patients' epithelium intact, but we also want the fast type 2 cross-linking reaction that needs oxygen. Therefore, we need to supplement oxygen for epi-on cross-linking.
So, a question I get all the time, and we're really excited about using supplemental oxygen. And I even talk about that sometimes in the office about how, there's different types of cross-linking. And I often talk or tell patients that, typically we think that the progressive phase of keratoconus slows down at about age 40. And that may be due to some natural cross-linking that happens just in the environment with exposure to typical UV light. So the natural thing for patients to say is, well, if I go outside and look at the sun, will I cross-link myself? And my answer is always, no, don't do that. We don't recommend that you go out and look at the sun. It's not going to work. You need to have the riboflavin in the right setting. But there is a natural cross-linking that occurs under normal physiologic conditions. And what's the relative strength of that physiologic collagen cross-linking versus the cross-linking that we see with UV light-induced cross-linking with riboflavin? I'm sure they're not the same, and you probably got more information on this than anybody I know. So, what is that difference?
So yeah, you're absolutely correct. There is a native enzyme called lysyl oxidase, or LOX, LOX, that cross-links in the native environment in healthy corneas. This enzyme cross-links primarily a unique combination of amino acid side chains of collagen. KGHR are the 4 amino acids, or lysine, glycine, histidine, and arginine. And so this can be contrasted with the oxygen-based UV-initiated cross-linking, which has multitude of additional sites, including amino acids such as tyrosine and tryptophan. And so we can state that the UV-based cross-linking could be more efficacious and add more strength to the cornea because it involves more sites and likely works much faster than the native enzyme lysyl oxidase.
So if we were comparing collagen cross-linking to something real simple like a hook and loop strip, right? Like Velcro, the oxygen-induced cross-linking or UV light with oxygen cross-linking has more hook and loops. It's stickier, if you will. There's more adhesion sites. It sounds simplistic, but would that be a way that I could describe that to a patient? It's stickier. Does that make sense to you?
Absolutely. There are more opportunities for crosslinks, therefore more opportunities for stiffer cornea.
All right, so now let's move on. So that's the UV light cross-linking with oxygen, but what specifically, we know oxygen is so important, but why is it so important to incorporate that oxygen supplementation into an epi-on regimen versus just the oxygen that's in the atmosphere? What's the difference there, and how does that play a role in cross-linking?
Thank you. That is really the central question. And so in short, increasing the oxygen concentration from the normoxic levels, which in the room air are 21% of O2, to hyperoxic environment, which we characterize as 90% or greater oxygen, increases the rate of stromal oxygen replenishment by a factor of greater than 4. Meaning in the room air conditions, the oxygen replenishes through the intact corneal epithelium into the stroma at the rate of approximately, let's say, 0.8 micrograms of oxygen per centimeter squared of cornea per second. If we create that hyperoxic environment with 90% oxygen, we more than fourfold increase that level of oxygen diffusion into the stroma with the rate of approximately 3.7 micrograms of oxygen per centimeter squared of corneal tissue per second. And so that's highly significant. And why is this important? It's important because with the epithelium on, when the UV light is turned on, the oxygen depletes. And so in the normoxic environment, we start with the stromal oxygen saturation between, let's say, 10 to 20%. And then when we turn on that UV cross-linking light, that oxygen is rapidly consumed and plummets to zero. And that's where we stop having the efficient type 2 cross-linking reaction and default to the slow and inefficient type 1 cross-linking reaction. That's in normoxic conditions. In contrast, in the hyperoxic environment, we start with the stromal oxygen concentration between 70 to 80%. And so when the UV light goes on, the oxygen level drops, but never to zero, and always maintains at the level at which it's efficiently able to support the efficient and fast type 2 cross-linking. And so we can state with confidence that with the epithelial-on procedure, normoxic protocols result in a complete O2 depletion, while the hyperoxic protocol results in a balance of O2 supply and demand and always maintains oxygen level in the stroma that's sufficient and effective to support the type 2 fast and strong cross-linking reaction.
So that's pretty interesting. So I think what you're saying is, the second you turn that UV light on, oxygen, in the cornea goes to, very low levels within a very short period of time. So we're essentially loading the atmosphere with oxygen to keep a higher level, to keep that type 2 cross-linking going. And just, as an idea would also be maybe, and feel free, if you don't feel comfortable addressing this, let me know, but is there also a role of pulsing the UV light? So you hit the cornea with UV, oxygen drops, give it a break, let the oxygen level return, hit it again, and it drops to try and keep a little bit more of the type 2 cross-linking going on, whether you do or don't have a hyperoxic environment.
That could be a theoretical approach, but in practice, basically the pulsing cannot be long enough to replenish sufficient levels of oxygen to allow reversion to the type 2 efficient cross-linking under normoxic conditions. And so this would lead to extremely long treatment times that would not be supported by your practice and by the patients.
Guys, I think that was a very politically correct way of saying, yeah, good idea, but that doesn't work. Not in the real world. So Tomas, tell me about this. A picture that sticks in my mind of collagen cross-linking is, and I forget what article it's from, but it's a picture of somebody holding a cornea and it looks kind of floppy. It's sort of drooping down on a forceps. And another picture of a cross-link cornea where they're holding the forceps and it looks like a diving board. It looks relatively rigid. So the idea is, look, this cornea is physiologically stiffer. Biomechanically, it is different. But how do you actually measure or study the stiffness of the cornea?
Thank you, Brendan. That's actually a really difficult question. And so in order to directly measure the stiffness of the cornea, we have actually developed an in-house system called optical coherence elastography that truly measures the actual stiffness, material stiffness of the cornea itself. And I would like to describe briefly the methodology, but before we do, let's explain several physics terms that are essential in understanding. So in material science and in physics, we measure stiffness in terms of shear modulus. And so imagine a water balloon filled with 1 quart of water. It's an underfilled water balloon. You take your thumb and you stick it in the water balloon and it really indents quite deep. And so now imagine taking the same water balloon and filling it with 4 gallons of water. Now the balloon is really overfilled, and if you try to stick your thumb in it, it resists. So that's kind of the definition of shear modulus on a specific concrete example. And in physics, we know how to measure shear modulus because it's related to the velocity at which mechanical wave travels through the material. Let me give you a specific example. Imagine waves on the surface of the ocean moving towards the shore. If the ocean is made out of stiffer material, the waves move to the shore faster. And if the ocean is made from less stiff material, the waves move to the shore of the ocean in a slower manner. And so that's what we basically do with the cornea. We mount an entire cornea and then introduce a mechanical wave at the apex of the cornea. So this is a circular wave. Imagine taking a pebble and throwing it into the calm water. It creates a circular ripples or circular wave on the surface of the water. And that is basically what we do with the cornea. And in the optical coherence elastography, we then record the propagation of this mechanical wave on the surface of the cornea, determine the speed, and based on that, we calculate shear modulus. So it's a very elegant system that has generated quite exciting results to date.
So you can physically measure the change in a cornea. There's no question that a crosslink cornea is stiffer or has a different shear modulus than a non-crosslink cornea. That's correct?
Absolutely.
And I guess a lot of the idea initially was we know we can make the cornea stiffer, but does that necessarily mean that your keratoconus isn't going to progress? You know, the two may be linked, but isn't necessarily true. But all the FDA studies for collagen cross-linking have shown that, you know, you both stiffen the cornea shown, I guess, in the lab, and that leads to a lack of progression, you know, for our keratoconus patients. So I think some of our earlier studies with cross-linking were proving that, you know, yes, we can stiffen the cornea with riboflavin and UV light, but now we've gone on to show that, or to try and show that oxygen is very important in that cross-linking procedure. And Glaukos has done a lot of work on here. So, you know, how has Glaukos studied that role of oxygen and demonstrating how important that is in the collagen cross-linking procedure?
So we agree that it is really central to answer that question. Is supplemental oxygen beneficial to corneal cross-linking under epi-on condition? And for that, we have designed a specific in vivo experiment in which we compare the hyperoxic protocol side by side with normoxic protocol with the corneal epithelium intact, with the same UV light emitting instrument and epioxa concentrations that we used in our 2 phase 3 pivotal studies. And so in this case, we used corneas from New Zealand white rabbits, which were in impaired condition. And one group was treated with the epi-on procedure under normoxic conditions without supplemental oxygen. And the second group was treated with the same protocol with epi-on under hyperoxic environment. And both groups received the epioxa-like dose of 10 joules per centimeter squared used in our phase 3 pivotal study at an irradiance of about 30 milliwatts per centimeter squared with that 1 to 1 second pulsing applied for 11 minutes, 6 seconds. And so this was an exciting experiment, and we made use of our optical coherence elastography instrument in which we basically measured the propagation of these waves and the increase of speed or decrease of speed across 30 different half meridians. So we are capturing basically stiffening of the entire cornea. And then when we integrate this data, we observed that the hyperoxic protocol with the epithelium intact resulted in 72% greater stiffness compared to the same epi-on eyes with the normoxic protocol. And so in detail, the normoxic eyes increased only by 18% as a change from baseline. The hyperoxic eyes increased by 31%, thus generating the 72% greater stiffness under the hyperoxic environment. And so this is really unequivocal and important conclusion that not all epi-on procedures have been created equal. Epi-on without supplemental oxygen does not work. And as evidenced by our 2 well-controlled large phase 3 studies of epioxa, epi-on procedure with supplemental oxygen works well in patients, is well tolerated.
And so I guess, you know, we're sort of almost, you know, on the verge of learning a whole lot more with epi-on and the role of oxygen. But it looks like with that rabbit study showing that the hyperoxic environment, you know, really increased the stiffness or the shear modulus. The idea would be that would give you, I guess, a similar result with a epithelium on crosslinking procedure as far as how it may work.
Yes, we agree that the epi-on procedure with supplemental oxygen, while preserving the patient's corneal epithelium, allowing patients to get treated on Friday and go back to work Monday, as opposed to having 2 to 4 week recovery time period with the epi-off procedure.
But I mean, Tomas, I hope you understand the impact that your research and the R&D has on treating patients with keratoconus. Supplemental oxygen, it seems to be so important, not only in maintaining that type 2 cross-linking procedure, but improving the speed of recovery, patients' function, patients' fear of having a procedure, an office-based procedure, and potentially really changing how we treat keratoconus in the office. It really is monumental. Now, I got to say that this podcast in best practices in keratoconus management has been one of the more scientific, less jokes, less talking about how we do things, but man, have I learned a lot about the role of oxygen and how important it is in the cross-linking process for collagen cross-linking. And Tomas, thank you so much for coming on with us. It's really been educational for me. Thank you so much to Glaukos for supporting the Best Practices in Keratoconus Management podcast. Hopefully we've discussed something that sparks an interest or will help myself and you treat patients down the road. And if you've enjoyed this podcast, or if you haven't enjoyed this podcast, make sure that you click the link in the description below to fill out a survey so we can learn more about what you like or don't like about our podcast. Thank you so much for listening.
Thank you so much, Brendan, and congratulations on creating this great forum.